come to us primarily, and we start lowering the rate of the stop on day before as per anesthetist advice they have to do, and start on day post-operative use. We also use physical therapies like sequential exercises. If the patient is coming from outside to me, it's quite often we start for 2 to 3 weeks plus, then we get a luckily diagnosed. We try to do it doctor and see whether it's having it or not, and then also continue the same treatment. If a patient is having a DVD or having a trauma which has been diagnosed, then we have in our economically hospital also, but we have IOACON and then
And how long do you continue the
we
prophylaxis?
normally keep it for 2 weeks, and then in our setting I start an aspirin doses.
Okay, well, I would like to invite Dr. Collins up. Oh, there are more questions? Please, questions are very important.
Sorry, just one
No,
comment,
don't be sorry, that's great.
Abhay had asked, epidural catheter is not a contraindication for giving DVD prophylaxis, so even you can leave a gap of about 6 hours, so if you've done the surgery in the morning and there is an indwelling epidural catheter, you can continue your night dose, and if you want to take the epidural catheter out, say, after 72 hours after surgery, you can leave a gap of around 12 hours between the dosages. So you give the enoxaparin at 10 o'clock at night, remove the catheter tomorrow morning at 10 o'clock, and continue with the dose at night time. And the question that I had for Frank was, say if you have discharged the patient at 7 days, do you have any objection of using the oral anticoagulants like levetiracetam, or do you continue with injectable?
I continue with injectable. I just don't feel that there's adequate evidence for not. Also, the other thing, very realistically, is in a fairly obese population, late drainage to start is not unheard of. And so even if somebody's been in the hospital, they're discharged, let's say day 5, 6, 7, whatever, and their wound is dry, so to speak, they can always reaccumulate drainage. So, you know, not that the low molecular weight heparins that are injectable are without it, but certainly there is evidence to show their incidence is less, and there is not good evidence at a total joint arthroplasty or standard hip fracture to say that the oral ones are appropriate. So I don't in my practice at this time. I'm waiting to see what the literature pans out over the years. Okay, are there any other questions? So at this juncture until approximately 3:30, we're going to go over some pelvic cases, and we have cases from both continents here. Dr. Collins is going to start us off with a couple of pelvic ring cases, and then we'll go from there. Thanks, Corey.
Okay, thank you. In going through the cases, we've got some real good ones, some very complex cases, some very high level of thinking cases, and I wanted to start with a very basic, simple scenario that I think we all will see, or will see us, just to make sure that we're hitting the basics. So this is a 57-year-old man with a widely diastase symphysis and open SI joint from a motorcycle wreck. He hits the emergency room and he's got a systolic blood pressure of 70. He gets his 2 liters of crystalloid and they get some blood ready. And this, I'll give you that this case is about 10 years old. So at the time, I think that's what was done. They were running the ATLS protocol and getting a little bit of blood ready for him and seeing if he was going to respond. He also had an open forearm fracture and I think a grade 1 splenic laceration, nothing that anybody was going to do anything about, but a little bit of a bleed there, but not explaining the hypotension. So he stays in the hospital, moves around to CAT scan. His systolic blood pressure never really improves above 80. So he's about 2 hours in. What would you all expect to happen at this point? Now this is about 8 or 10 years ago, something we've touched on today. The pelvic binder, right? So again, this is a while back and it's not pretty. It's not as elegant as a well-folded sheet to distribute the pressure better, and it's probably a little bit high. But you can see that it's done a pretty nice job of reducing the ring. So, hematoma, normal pelvic volume, current pelvic volume, and you can see that this tells you it's a few years ago because we're all electronic now, but at 10:10 I arrived to splint the pelvis, which is remarkable because I do everything I can not to go to the emergency room. And at 10:30 on the charting below, he goes from a blood pressure of 100 or below to a systolic pressure of 131. So I think the power of this tool is demonstrated here very clearly. And, you know, with a $3 sheet and a couple of clamps, you can really make a difference. So everybody is comfortable putting on a sheet. One guy gets on one side, one guy gets on the other side. We pull. Maybe somebody internally rotates the legs to bring the anterior pelvis together. And we get it good and tight. And we have an opportunity to resuscitate a patient better. He went to the surgery that day, washed out his open forearm, and I put an anterior X-fix pin, set of pins in. Now I would put in a Hanover frame in the OR. This is, like I said, it's old. And then at about 3 days later, he came back to get his pelvis definitively repaired. So I wanted to show this as a tool for all of us to use, and it does save lives, and it will save lives, and I think that's an important part before we get into the high-level, sophisticated part about how we want to fix the massively comminuted pelvic ring with the associated acetabulum that Frank's going to show you next. Okay? We'll stop there. Frank?
That's fine. That's the reason I can bounce back and forth. That's okay. So that was a good case, I think, and a few salient points, whether it's a sheet or an X-fix, that are probably important. You want to try to use help, and not so much the sheet or the external fixator pins as your reduction tool, because that actually deforms your ability to reduce. So if you have two people on either side, internally rotating the legs and pushing in on the thighs, pushing inward toward the midline, just below the level of the greater trochanters, and you're tightening your sheet that way, that can be helpful. You don't want to be pushing on the iliac wings, because one, if you have an iliac fracture, that'll displace it. Two, that can cause an abduction deformity of that hemipelvis if there's significant posterior injury. When you put a Hanover type frame, or even the older type iliac crest frame, using the pins will also create deformity. So you basically want to use these external fixators more as a neutralization device, or a device to hold your reduction you attain through other people. And that's going to bring us to this case over here, where I made the mistake of not doing such. So can we...
The other thing I'd add to that is that if you've got a vertically unstable fracture pattern, somebody needs to pull on the leg too. So you may need 3 or 4 or 5 people to help you gain the reduction. Internal rotation is very important to gain length.
Correct, absolutely.
And 2 to just apply the sheet. So
Yeah.
5 people.
Yep, and also put them in skeletal traction, because that'll stop the bleeding and help reduce your deformity. And we were talking about traction in the subacute or chronic situation. It can be very helpful otherwise. So this is a young lady. She's in her mid-20s. She was hit by a motor vehicle, and she came in with emergency medical service, and this is how she presented. This is her initial screening X-ray. So would anybody like to comment on what they see here, maybe what they think is going on, anything in particular? So she had this injury, she had an ankle fracture, she had a lung contusion. These are the other issues outside of the pelvis she had. So this is an interactive session. Anything you see or not? Well, the two springs over here are a key to something, right? So they put her in a pelvic binder, and I'd like to ask the audience, when you do have your ambulance services arrive at the scene, Do they have pelvic binders, or have they been trained in using a sheet to help stabilize patients that are very externally rotated and suspect a pelvic injury? Now, I see a lot of heads shaking no. That's something that probably has become a little more popularized in our region over the last few years. It was not that common many years ago. And granted, there are some, Dr. Magoo talked about the vectors involved in the classification of these pelvic ring injuries. Yeah, but so the binder may have done something wrong here, not right, possibly.
I think still, I was walking through polytrauma. You met me last year in October. And there was a paper also on pointers. They said, no, recently, even if it's lateral compression injury, the binder has a role. So that's why I asked you this question.
Yeah. So they're being applied as standard protocol now in many of the emergency medical services, the ambulances, when they are picking up the patient. But if you note, though, anteriorly there's an excessive amount of compression across the midline, as you can see here. So basically, she was brought in. They were a little less concerned about having any stabilization, formal stabilization done in the pelvis, the general trauma surgeons, because she's being stabilized, just like we would sort of with an external fixator, at least temporarily. And they were more concerned with the airway, with the lung contusion, etc. So how many people here would be comfortable once this patient's cleared to go to surgery without a CAT scan?
Go to surgery for what?
For a temporary surgery.
Well, that's exactly what I want to hear. Do you know what you're going to surgery for? Do you need the CAT scan? Do you need to know what you need to do? And that's a very good point. Is it going to be definitive or temporary? So in many of the centers, they screen people with a CAT scan the minute they come in. So we had the advantage of having some cuts of the CAT scan here. And we can see that there's obviously a sacroiliac injury on the right, and on the left side, a pubic root injury that really was not that clear on the initial screening film, at least not to me. Yes?
I just have a question. I mean, if you have a patient who is stable enough to undergo a CT scan before he goes to theatre, do you think there's any merit in giving him a contrast and checking, doing an angio at the same time? Because it doesn't really take much.
Well, the question...
Is it indicated? I mean, is it needed?
The question is the side effects of giving all these people contrast and potential renal issues, etc., contrast allergy, etc. So if this person's reasonably hemodynamically stable, and the main concern here is their pulmonary status, basically, then, you know, in my opinion, and the way this patient was managed, just a blanket contrast may be a little aggressive. What's your opinion on that?
No, I was wondering whether if you have time to take a patient who is hemodynamically unstable,
that's a different scenario.
Borderline area where you can actually maybe diagnose the vascular injury at the same time, because it doesn't really add up apart from the insult that the contrast is going to cause.
Correct. And you also, though, if you're not doing it specifically in interventional suite, you can miss the time on the contrast to define every single arterial injury as well. That's the one thing that can be an issue also. So it's not necessarily appropriately sensitive, if that's exactly what you're looking for, outside of a true arteriogram for that purpose. But in any event, so now at this point, if they tell you, they say, okay, let's let her get through tonight, we want to bring her to the intensive care unit, we would prefer you not to go to the operating room for at least overnight, maybe for a whole day. And then we would like you to only do a very limited procedure. What would you do? Let me ask Ramesh, what would you do?
In this patient, I think I would go for application of skeletal traction, because there is some element of vertical shear, and probably go for a Hanover kind of a external fixator as a temporizing measure.
I think that's very reasonable. And so we went to the operating room and we applied an external fixator to the patient. And we tried to do some posterior stabilization at the same time. When she was on the table, you could actually dynamically move on the left side, which didn't appear on the initial CAT scan to have a sacroiliac injury. You could move that hemipelvis and it would gap. So we figured we'd stabilize that in place. But the mistake here, there's a mistake, certainly a mistake that was made. The question is, how many people here would find this to be an adequate reduction with the radiographs that are present? So Corey's the only one that would think this is adequate. So I was mistaken as well, initially thought it was adequate, and then I went back and re-looked at it when they said about 3 or 4 days later we could bring her to the operating room for definitive care, that her other organ systems were stable enough.
So Frank, you've taken her from distress to the point where she's now hemodynamically stable.
Right, she can indefinitely wait for a definitive procedure at this point.
So,
Yeah.
but you've done a lot of work here, and what's the downside if it's not perfect? You get a CAT scan and come back and fix it.
Correct.
What you've done here is you've stabilized the pelvis in all quadrants, and at least it's close. I would say that the C-arm is not sensitive enough to really show much deformity, because these x-rays do look reasonable. But at 5 days, if you're not going to be able to come back, at least in my hands, getting close reduction for percutaneous screws is difficult. So at least you're close, and I think you could probably make a minor adjustment in a couple of days if you had to, if the reduction's not what you want.
Yeah, and that was the thought process involved. But even critically looking at these fluoroscopy afterward, you can see over here, if you compare to sacroiliac joints, there's an overlap over here. And there's an asymmetry with an overlap as well as an asymmetry with height. And if you look at the symphysis, you can see there's a bit of a tilt and still a bit of an overlap, especially a little bit of an overcompression and almost like a slight abduction of the right-sided hemipelvis, right? But in full agreement with Corey, this is a reasonable way to stabilize until an indefinite time when you're allowed for definitive care. So the next step is she was stable enough for definitive care. So how many people here would have left this as definitive care?
Can you repeat that?
How many, show of hands, how many people, if they said, you know, she's clear, would you have left this as her definitive care? You know, left the Fixation 6, 8, 12 weeks, whatever your protocol is.
Do you have any pictures post-operatively which better define the reduction?
This is what we have available to us.
And then closing propubic catheter or nothing of that?
No.
I would probably exchange that to a superficial plate, at least anteriorly, and at the same time reassess the reduction.
Reassess the reduction posteriorly. All right, I think that's reasonable. Anybody else? Would anybody else?
Information, right?
Yeah. So when we brought her back, this was the more information. So we left her external fixator on, and you can see we have this Jungbluth clamp over here. And I neglected to save the fluoros that refuse to allow us to reduce anteriorly anatomically. So that in itself is defining that what we felt was off posteriorly was probably even more so off than what we subtly appreciated on our fluoroscopy. So the patient is supine at this juncture. So we did a lateral window, or went on the internal iliac fossa and exposed the joint. And going back to our prior fluoroscopy, where you can see that things are overlapped, it's slightly elevated, there's a step off over there, it actually was much more accentuated when you did the open approach to the SI joint.
But you're also pulling through a pubic root fracture on one side, right?
That's on the left side, which is non-displacent. Thick periosteum was intact. There was no gapping on that side. And we also maintained the external fixator still to help us a little. Granted, it's proximal to the pubic root fracture on the left, but it still helped maintain a little of the stability. It was very far off on the right SI joint. I was disappointed when I saw that. But now the other question comes into play, what are you going to do? So if you take your sacroiliac screw completely out and you've clamped down anteriorly, right, you're going to have potentially a little bit of a difficulty to reestablish your reduction because you're going to re-gap in the back and have some form of a vertical translation potentially. So one alternative is we removed the screw, left the wire, we put the wire back through the screw, removed the screw, And then, just like we showed that little trick with the sawbone about the reduction with the Farabouf and then the under contoured plate, applied both of those, and then re-drilled over the wire. Because we could have probably forced a screw in again, but its likelihood would be to go down the old trajectory and fight the newly reduced joint. So we were able to maintain the wire. We knew it was in a safe corridor. It was flexible enough with the size of the screw around it to allow an appropriate reduction. Re-drill and then reapply the screw as a secondary point of fixation. And we ultimately removed her frame. And this was her final radiograph. Unfortunately, she had not followed up, social issues really aside. We at least felt at the time we delivered her a reasonable pelvic ring result. Are there any comments on this case before we move on to another? Yes?
Two comments. First is that why is it that when we talk in meetings and show our cases, our patients do not seem to have the complications which the literature writes? For example, the iliosacral screw, 5 degrees of angulation off target, and you have a 10 to 15% higher incidence of complication. But whenever we do talk about these patients on the forums, we don't seem to be talking about it, and that's one. The second thing is that it's fine to be asking ourselves the question that what do you do next on the initial x-rays, but given the preliminary fixation, probably a more prudent thing to do is that if one is not very happy with just a small window showing the reduction that it is showing, it was just prudent to go in and do a proper x-ray again and then decide what they needed to do, rather than already have an anterior fixation and then have to pull out a posterior fixation and go back and do something again.
Well, we didn't have an anterior fixation. We just had a temporizing external fixator. Just, we didn't have a formal definitive anterior fixation. So we returned for the formal definitive fixation, and that's when we realized we were unhappy with our ring. We were a little overconfident. It actually was, a lot was hindsight in appreciating the malreduction initially. We were too confident, and when we went back to put the plate on the symphysis is when we realized we were not reduced as well as we should have been posteriorly. And that's why we had to redo posteriorly.
Actually, I'm not an iliosacral screw person, and I've always questioned the fact that whatever we do seem to, the law is like chip routes has written so much about iliosacral screws, but a lot of times you do need to go in and reduce those fractures openly before you put in even the iliosacral screw. So, I really don't know what percentage of the time would you go in and put in an iliosacral screw, or is it just the comfort zone that individual surgeons have with a particular modality of fixation? Is it that?
I think it's a combination of both. If you're comfortable with it, you may push the indications on having the screw help you with your reduction. I think over time, as we've all, especially myself, have gotten more critical in my practice, if I try to reduce something in the front and it's not that there's a gap that's symmetric, that the screw will just directly compress if the right trajectory, but if there's other deformity going on, too much abduction or adduction, a major rotational deformity or a vertical deformity, in those cases then I'll formally open to get the reduction before applying the screw. So you can have the reduction with your clamp and put the screw in then as well. So, it's really on an as-case basis, but unless I'm confident that it's parallel, the gapping, and that the screw can reduce it, I won't go to try to just percutaneously reduce it. I may go to percutaneously stabilize it, but that's different.
Do you all do more open reductions or closed reductions, or where are you at on time? And how does time play into that?
If I had to choose between putting in an iliosacral screw and an anterior sacroiliac plate, I'd go for the anterior sacroiliac plate for the simple reason that I'm happier and more comfortable doing it.
Our problem is that we do not get the patient. If I get the patient on the 4th day, 5th day on my table, then I am putting the screws. If I get on the 7th, 8th, 10th day problem, then I don't get the reduction what I desire for a proper screw positioning. So I tend to go for a plate or the post.
And it also depends on the indication for the screw. We keep calling them iliosacral screws, but if we're using them to stabilize a non-displaced but complete sacral fracture, then it's less of an issue, right? Because it's not a reduction, it's a stabilization. So it really all depends also on what's the purpose of us doing the screw, which is, there are many purposes that we're doing this posterior stabilization.
Mostly our setup, we are doing this screw
Correct.
Displaced, most of the time we treat them non-operatively. So we treat them surgically for displaced fracture, which we reduce on the table, get the reduction, and then because by third, fourth, fifth day we get a reasonably good reduction. We put a screw because we are likely to get an anatomic reduction where screw insertion is safer. When it becomes 7 days late or 10 days late in a displaced fracture, when you try reducing, you can't reduce it to the expected level. So then we have to go for an open reduction, and that's the reason that at that time when we go for our plate fixations.
Yeah, these are all excellent points. So I think there's a very nice pelvic case. There are many acetabular cases that were provided for presentation. There's a very, very nice pelvic case provided by the Indian faculty that I would love to present. It appears from my understanding that Dr. Acharya is not currently here, but it's a very nice case that goes over some principles that I would like to go through. And he provided a very nice history for us. So this is a 17-year-old male, restrained driver of a car, speed undetermined, was T-boned, so hit perpendicularly to the car. He was ventilated on the scene, unstable in the emergency department, and received a massive transfusion protocol that was started. Head injury and intracranial pressure monitor, bilateral pneumothorax, chest contusions, bilateral chest strains, pelvic injury, right femoral neck fracture, and right closed tibia fracture. So all the injuries appear to be on the right-hand side orthopedically. So this is what we have here. So any comments from the audience on what we have? Let's define what we have. Would anybody like to define what they think they see that we have? Corey, can you maybe lead us through what you think they see, or that you think we see? Because there's some subtle aspects here too that take secondary look.
So can I make a little problem list?
Sure.
Okay, polytrauma, head injury, chest injury, tibia fracture closed, right femoral neck fracture, comminuted, pubic diastasis, and it's hard to see the back of the pelvis, but maybe something in the back, and then a complex right acetabular fracture. So, and we are, I guess the next question I would ask is, do we have a patient in relative extremis? He's got a hole in his head, 2 chest tubes, and probably not up to much. That's my supposition, but we haven't heard anything about blood pressure.
Correct. So he received a massive transfusion protocol. He was defined as unstable. So we have to assume he was in shock at some point. All right?
Or he's not as close. He's hanging on.
He's hanging on. And with reserves of a young person, sometimes it's harder to tell. They don't give you as much of a clue. So I guess the next step here is, one, what are our concerns? Our concerns are obviously the pelvic ring, the acetabulum, AVN or non-union of the femoral neck. But also we have a comminuted tibia, and we have a basically unreliable patient at this time, right? So compartment syndrome is another concern here as well in terms of preservation of extremity, not to lose light of this in our pelvic talk. So I think most of us agree our next step we would get is a CAT scan. So does the CAT scan help in telling us much of what is going on here? So I think they provided a few more cuts for us. We can go back, evaluate the 3D reconstructions first, if you'd like, where we can see that actually this is a fairly complicated acetabular fracture, although not significantly displaced, is a both column. We have sacroiliac widening, as you can see here. You can appreciate the posterior involvement as well, the posterior column. We see our femoral neck is highly comminuted, which adds to some complexity. And then we see also we have a sacral fracture as well. So injuries, head injury, bilateral pneumothoraces, pelvic, femoral neck, and closed tibia. So what are our priorities? What needs fixing and in what order? What would you say?
I think this is a case which needs to be treated according to the principles of damage control orthopedics.
Absolutely.
This patient is in his extremes, and I think he needs to have the most minimum of the surgeries that can be done.
Well, let's define first, is any of the reason for his extremis orthopedic likely? But their location and displacement, that wouldn't be the first thing for me to think about.
Displacement doesn't seem to be massive, so we need to look at his chest drains, the speed with which the chest drains are draining out, whether the hemothoraces are actually need to be doing something to actually actively go in and stop the bleeding in his chest.
And labile blood pressure with a head injury too can be a concern as well.
Is there anything you do in the ED or in the ICU?
Well, obviously you would check for the rate with which the chest drain is pouring out. And if it is pouring out more in an hour, say more than 500 or 700 in an hour's time, you really need to think about an active bleeder inside the chest.
Would you do any orthopedic procedures on it in the ED or ICU?
I would probably just put him in a below knee back slab and probably a supracondylar pin.
Traction pin?
Traction.
Yeah, that's what
Yeah, definitely agreed.
Anybody do anything different at this point? Okay. Oh.
We'll probably use 2 pins, one for the tibia fracture, a calcaneal pin and a supracondylar pin, and then put him on a binder and just wait for his chest injury as a head injury to stabilize out. Whereas just keep the patient hemodynamically working all this while that we're waiting to fix the bony injuries.
So let's say we get to a point where fixation becomes feasible and the patient is stabilized. So we still then at that point we have to prioritize how much we want to do. We have to consider also if we're in the middle of one of the many procedures and have to stop, where do we hope we at least got to?
Hey Frank, if,
Yeah.
So say he's day 2,
Okay.
and his intracranial pressure is not too bad, and his ventilation is okay. Do you have any urgency to get moving on this, or how do you all feel about how much do we push, or do we just lay back and wait until we're told, okay, it's time for ortho?
No, sorry, you were going to say, Mahesh?
Trying to get back into would be between 2 to 4 days.
Yeah, especially if you're nailing a long bone, potentially. But I think at that time of 2 to 4 days, I would be comfortable on fixing the femoral neck and external fixing, X-fixing the tibia. I'd be comfortable with. It's just easier for transport, monitoring if a compartment issue does develop, etc. So I would be comfortable X-fixing the tibia and ORIF-ing the femoral neck. Then the question comes into play, how do you want to ORIF femoral neck? Sorry, go ahead.
You're very right to point out that especially if you're looking at nailing the tibial fracture, there's always a problem of embolization and stuff. But you put in an external fixator, then how long are you going to wait to position your patient if you want to treat the acetabular and the sacral injury surgically? That would be a deterrent in positioning of the patient. So somebody's got to take a call. I would probably just take my chances and think more towards the benefits of an unreamed nail and put in a nail there and stabilize the femoral fracture for the simple reason that when we do fix our PelvisAcetabular injury, we would need to have a reasonably stable moving limb.
I agree with that. I like the idea of nailing it. Even though there's a pulmonary injury, I don't think the tibia is overly, guilt-ridden about that embolus.
Yeah.
I think it's less of a deal than the femur.
I don't know how it is in everybody's institution. Sometimes you get these arbitrary times. You're told, today you can bring the person to the operating room for 2 hours, 2.5 hours, 3 hours, whatever. You're given an arbitrary time by the general trauma ICU doctor. And in those cases, I would use most of that time on the femoral neck. If at the end of that time I felt it was safe for the tibia, I'd go for it and just do the tibia.
So I'd go the other way. I'd say, I'll be the devil's advocate. I would say that I would pick off the tibia relatively early, because then you can at least pull against it, you get them out of traction. And maybe it's a little stress test, but I can nail that tibia. I think most people can nail that tibia quickly, predictably, and without problems. And the rest of this may be difficult. And you may get, like with that femoral neck, you may get into a case where you're not all that happy and with how you're doing, and the patient may not be doing that well. So
that's not the priority.
Yeah, and so this is where a little bit of the art of medicine, I think, comes in. I think some of us are thinking one way and the other, but I don't think either is necessarily wrong. In terms of unream versus ream nail, I think probably the biggest time of embolization is when putting the hardware in the canal. If I think a patient's healthy enough to nail, in my hands, they get a ream nail. Reaming, when you say about, some have said that unream nails, well, at least it saves on time. It's such a nominal matter of seconds it saves on, minute and a half for reaming. So to me, if I nail, I prefer to ream. That's preference.
We could argue one way or the other, but
Correct.
at the end of the day, the literature says there's no difference.
Correct, absolutely right.
They just say that the patient has chest injury. They are non-contusions.
Mhm.
Internal nailing should be avoided.
So
It's a
what-
polytrauma patient.
What should be avoided, I'm sorry?
And there's chest injury.
Yes.
Non-contusions also.
Yeah.
And he's a polytrauma patient. There's head injury. So internal nailing should be avoided.
At least for 4 or 5 days.
Yeah.
Right, yeah, and that was more looked at in femurs, but for 4 or 5 days, and that's why we were saying you can X-fix them and stage them for the nail, if you like, ultimately.
Well, coming back to the thing that I said first, that see, at the end of the day, we are not just looking at a femur neck fracture and a tibial fracture. We also have a huge giant in the pelvis and acetabulum sitting there, which we might need to treat surgically. So that's what I said, that I back myself to think that unream nailing and ream nailing doesn't make a difference. And somewhere down the line, you cannot endlessly, if the patient is stable enough, you would have to take that risk of also taking a decision early on that somewhere down the line, this patient needs to get their acetabulum and sacrum fixed. So,
Neck femur first.
no, ultimately the decision is that somewhere down the line, the acetabulum also needs to get fixed. So if you put them into a fixator, then how long do you wait? It's a big pain positioning the patient on the table. With if on the day you do need to go in and do an acetabular fixation. So from considering that in mind, probably I would just take the risk, explain the risk to the patient and the relatives, and go in and fix the neck and the tibia.
Well, on a proximal tibia fracture, you often have to cross the knee with your fixator. But this level of tibia fracture, you probably, if you had chosen to put a fixator on, could still maintain a distal femoral traction pin, could still flex the hip and the knee if the hip was fixed, the femoral neck, and you apply traction through the femoral pin to help you with your acetabulum, if you were doing everything supine. So that still is possible. This person, for me, wouldn't be going prone if they had a fixator. Or the day of doing the acetabulum. If that person's that unstable, I wouldn't be doing their acetabulum until they were stable enough to have their silly little tibia nailed, you know? So the day of the acetabulum, you could take a few moments and nail the tibia too. It depends.
If I may say, sir, my order or priority of fixation is neck femur as fast as possible,
Mhm.
as soon as the general condition allows me to do it. 4th to 5th day, if the patient is stable, I'll go in and fix in the acetabulum.
Mhm.
Clearly, it's in both column fracture,
Mhm.
not much displaced. So with ido-inguinal approach, you can easily do the entire fixation of the pelvis and the acetabulum.
Mhm.
And if required, and if the patient anesthesia general condition is there at that time, I might do a fixation of tibia. Tibia is a diaphyseal fracture. Your place, my place, Sarmento, everywhere people have said that it can be treated. We should not forget that tibia can still be treated in a plaster. If not, it can still be operated after 10 days without much deformities. Whereas neck femur requires immediate fixation, acetabulum and pelvis will require early fixation, and then comes the tibia, which can be treated by a plaster or a slap at that time, and over the next 2 to 3 weeks, a diaphyseal fracture can be fixed.
I agree and I disagree. You can't wear Sarmento brace in surgery. It's not going to help you there.
Just give you an example that
The leg's flopping all over the place. I want to get that thing stabilized early, relatively early. And so if we decided it's a both column acetabulum, right? What about approach, and how would you approach that, and how would you approach the hip? Would you do percutaneous to the hip, or and what device? So let's talk about the hip a little bit.
So who's going to try to do a closed reduction and fixation of the hip? So everybody wants to do an open reduction of the hip, of the femoral neck. Is that true? Right?
we can try close reduction. We should So I close reduction for the neck of the femur. Why can't you try? You should try.
Well, that's why I asked, what would you like? All right, so, okay, now let's say we're not happy with the alignment with a closed reduction. What would, considering that we need to take care of this both column acetabulum, what would you use as your approach to approach the femoral neck for your open reduction? Surgical approach. What would you?
Frank, can you go back to the CT, or the CT, the 3D CT? So what approach, I mean, you've got to figure out your approach to the hip to figure out your approach to the acetabulum and vice versa.
For this fracture, we want to fix simultaneously both column fractures and neck fracture. I think ilioform approach is quite useful approach.
Okay, you can, that's an option.
Yeah.
That's an option.
You can do decompression of the capsule, neck finger,
Mm-hmm.
at the same time by giving a TNCM,
Mm-hmm.
and you can see the whole of the shear column and you can fix it. So both fractures can be done simultaneously.
Okay, so
As far
we,
as the approach is concerned.
so we have a vote for iliofemoral approach and definitely reasonable option. How many people here would choose iliofemoral approach as their way of treating this injury? By a show of hands?
If close reduction fails,
Mm-hmm. Yeah, we're just going to make an assumption that close reduction fails. Dr. Sen, you have anything to contribute? How would you approach these?
I'll have a separate approach, Watson-Jones approach for the fracture neck femur.
Mm-hmm.
And because it seems to be a comminuted fracture, probably may not really be comfortably reduced with the close reduction.
Mm-hmm.
So I'm more likely to have a reasonably aortic reduction at the neck femur with a separate dedicated approach to the neck.
Watson-Jones you would choose, okay? And what about for the acetabulum pelvic injury? What approach would you do?
I personally use a iliofemoral approach in most of my cases of this kind with, if required, stopaz edit or fennel steel or stopaz edit.
Mm-hmm.
So I use iliofemoral and stopaz or fennel steel depending on the material displacement as much as this is the approach which I use mostly.
And any other options? Any other ways? Corey, how would you?
I don't know, can you just summarize what we've heard so far?
So we've heard iliofemoral approach. We've heard a combination of Watson-Jones and iliofemoral approach for fixing all the proximal femoral and acetabular injuries.
I think I would throw out there Watson-Jones for the hip and a ilioinguinal maybe with a stop up for the acetabulum.
Yeah, I personally, I probably would do a Smith-Peet for the hip, take it up proximally to over the iliac crest and do the lateral window of the ilioinguinal with that. Separate lateral incision for my hardware for the hip, and a modified stopper approach to come through and address from that angle, and I'd leave the middle window alone. So that's what I would do. So let's see. Yes?
It's easy to get posterior column screw from the lateral window, you think, because of the combination?
Yeah, as a matter, tomorrow we have our fun little debate of stopper, modified stopper versus ilioinguinal, and I think modified stop in isolation probably is unrealistic. You also should do the lateral window for this purpose, and also if you're going to take your brim plate all the way up. But in the last few years, I haven't done an ilioinguinal because I've just combined the lateral window with a modified stopper. And if for some reason there's an issue, you can always then, at that point, get a lot of fixation quickly with low blood loss and low complication and flip them and do a coker to finish off posteriorly, as long as your fixation doesn't inhibit the posterior column.
No, in this particular
In this patient, no. This patient, the posterior column is not much of an issue here at all. And so it would be relatively straightforward to get posterior column fixation in this once you reduce it, and in my opinion. So let's see what was done, because I know at 3:30 you guys have a hands-on workshop with the Indian faculty. So the owner of this case went supine, I think we all agreed, on a radiolucent table, prepped in the right leg, did the femoral neck fracture first via Smith-Peterson, but used K-wires as joysticks. Before I show the fixation, what sort of fixation would the audience do for the femoral neck fracture? What's that?
I would do a short plate EHS with a zero patient.
DHS anti-rotational screw, I agree with you on that one, very personally. Any other options? Screws, just plain screws, cannulated screws? Cannulated screws, Corey, what would you do?
DHS.
DHS, we have a bias on that one, right? And then, other question, would anybody use a blade plate or a DCS on this? Anybody? Blade plate or DCS? Okay. Okay. So really two things, either cannulated screws or sliding hip screw and side plate with an additional screw. So the author of this case chose to do multiple cannulated screws. So let's critique a few things. One, are we happy with the reduction? Or let's make the question easier. Is anybody not happy with the reduction? And if so, mention what you're not happy with. Definitely is some conversation going on. Any comments? Any comments on the fixation? Is anybody unhappy with the fixation? I'm sorry? Fully, that's a very good point. So it doesn't allow for any ability of compression or collapse.
I think the principle that they have used is probably different because they cross the screws as well.
Yep.
Maybe it's just a positioning screw.
They may want to avoid collapse because of the comminution. That may have been their mentality. Personally, for me, even a little bit of shortening I would take on this intra-articular fracture or intracapsular fracture. I believe over time a bit of shortening with very stable rigid fixation, but the ability to compress some will help with healing. I think ultimately resorption happens at the fracture ends with this sort of fixation in the femoral neck and leads to a bit of a higher rate of non-union. But the mentality is understandable here.
The other thing is you get a hint from the upper left picture that there's some distraction, and none of these implants have the ability to compress. So are we fixed in a gap, in a fracture gap state?
The head is rotating actually. The femoral head is rotating. It is not, you cannot see its full profile in this view.
But the view is in external rotation again. Lesser protector is set fully.
So if it's in full external rotation, then there will be more of valgus. So that external rotation shows that head is rotating.
I agree. And I think up here, it may not be rotated, but it may be gapped in the cephalad aspect and in varus, and then somehow or other between the picture on the upper left to the picture on the lower left, rotation got added in also, maybe when hardware was applied or whatever.
So the thing's definitely elongated.
Mm-hmm.
Some sort of, parallax or something from the C-arm. So it just makes you worry that thing's not compressed.
So for the acetabulum, percutaneous iliosacral fixation was done, or I would assume was percutaneous, and I think that's reasonable. It wasn't really displaced, it was more to stabilize. And then individualized fixation was done for the acetabulum and the symphysis. So how many people would have done their, so I think we've had a discussion about the femoral neck, how many people would have done their acetabular pelvic ring fixation the same way? Or are there any differences? Please comment. Vivek, you would do it exactly like this? Yeah. Would anybody do one plate coming all around? It's because maybe it's not as much in terms of balance fixation on either side of this pelvic brim plate. So if one plate incorporated both injuries, that could potentially give a little more stability or balance fixation on both sides without being interrupted in the middle. That might be something to consider. But certainly looks reasonable in terms of pelvic ring, and the acetabulum looks very nice, very, very nice. So these are the other views. It looks very, very nice. It appears this person has an odd-shaped contralateral femoral neck head with some sort of a cam and a little bit elongated on their other side, but it does look a little asymmetric. But the pelvic acetabular work looks good. Any comments? Any other comments? Mahesh, are you comfortable with the posterior column fixation, screw fixation? Looks pretty good, yeah.
If you see the inlet view, the iliac fragment is still not stabilized. In the inlet view, if you see.
Right there?
That fragment, the lateral ones, where there is a reduced relax time.
Mm-hmm.
Below this fragment is still seams.
Yeah. So right here, you're saying this fracture really doesn't have much of any stabilization. And and you can see that over here as well. So they probably focused at the joint instead of working on the principle of going from peripheral to the pelvic brim, which probably more of us would have done. So this is the last slide of this case. Coming for 6-week check next week. Anything to do for the femoral neck. At this point, let's just say the surgeon, or you're the surgeon, you weren't totally happy with the femoral neck, and they're about 6 weeks out. Would anybody here revise that now, or would you wait and see what happens? How many people would revise this at the 6-week mark?
Would what?
It's your choice. If you're revising it, you got to book the case. Would anybody revise this at 6 weeks if you realized it's a little varus, a little rotated, a little elongated? Would anybody revise this? Or would you just wait and see if you needed a Powell's osteotomy down the road?
Wait and see.
I'm all for that. Wait and see. This patient's been through a lot. Yeah. All right. All right. Well, I have to say thank you very much for coming to the didactic session today of the Pelvic and Acetabular Combined Program of AOS and IOACON. It's been a great pleasure to meet all of you. Tomorrow we have another good day which focuses on acetabulum, and we have many complex acetabular cases that have been provided to us for the end of the day discussion. And we'll be starting at the same time we did today. So thank you again, and now there's your hands-on workshop. Thank you.
For this demonstration part, we'll have the video first. This thing is symphysial stabilization. So.
Pelvic fixations, fixation of the symphysis pubis and transpubic instabilities. In the plastic model, a pelvic instability type B with external rotation of the hemipelvis is simulated. The injury includes a symphysis disruption and a disruption of the anterior sacroiliac ligaments. The posterior sacroiliac ligaments are intact. The attachment of the rectus abdominis muscle is marked in red. After injury, one side is normally disrupted. Further dissection has to be avoided for prevention of hernias. Reduction is performed with the use of the pointed reduction forceps, which is placed in or around the medial cranial part of the obturator foramen. For stabilization, the 4-hole 4.5 DC plate is used. On rare occasions, the 3.5 plate is applied. The anatomic model demonstrates the close relationship of the implant to the joint. Projections is therefore mandatory.
Like this, a smaller Homan, right? You can use a blunt tipped broad Homan, small one, and the Homan will be here, and your superior pubic ramus is exposed, right? So you just clear the debris out from here. And what is important to do before doing this fixation is that your patient should be catheterized. You should have a catheter into the bladder, which will help you feel that you're not going to anterior, you're not injuring anything, right? And it is great. There's no collar mic. Collar mic hai kya? You split the recti. I prefer to split the recti, and I have two Homans, one on either side of the pubic tubercle on both the sides, and it gives a adequate enough visualization. And you just put a finger, it will go right up to the anterior border of the anterior pelvic brim, right? So the important thing, there are two things which are very important before you undertake the symphyseal plate stabilization. The first thing is that before you proceed to do this surgery, your patient should be catheterized, right? So he should have a catheter into the bladder which will act as a guide in letting you know and letting you feel that you're not going to anteriorly and you're not damaging anything, right? That is one. The second most important thing is that a lot of times we tend to use the bladder retractors just as a safeguard, right? Because that was more important initially when somebody...
The camera is not at the right place. Camera is not at the right place.
That's fine.
Just one. Just come here. Camera was here. Here.
Yeah, that's right.
Yeah.
That is the camera.
So, having the bladder retractor here is essentially just to make sure that we are not damaging anything anteriorly, because it's an unnecessary fuss if we damage the bladder. So it's great to have a bladder retractor. We tend to do it most of the times. And what it was essentially needed for initially was, if you want to put in an anterior plate, then you really need to know where your screw is ending. But even when you're doing a superior fixation, which normally we tend to do, it's an important thing, and it's an important geometry of fixation. So you've got your retraction done, you've cleared the fracture, you've cleared it of any debris or fragments here. Then the next most important thing is that you can have two kinds of a situation. One where the displacement is within 2.5 centimeters, and the other is when the hemipelvis is not only displaced, it is rotated, and it tends to go upwards and outwards, right? It tends to externally rotate and it tends to go upwards and outwards. Because the process of failure of the posterior limb is anterior, middle, and then the posterior sacroiliac ligaments. Unless it is a direct posterior injury where you tend to have a shear or you tend to have a directly unstable hemipelvis. So this pelvis will tend to displace laterally and will tend to go higher up and upward, and it's essentially going to externally rotate. So it all seems very easy to do on a bone model, that you just pull it back and it will hold and it will come down, but sometimes it's a problem. It's not easy to get the hemipelvis back and held and reduced in a position, because what happens is sometimes it tends to there is a loss of the anterior sacroiliac ligament complex, sometimes the middle sacroiliac ligament complex, so it tends to open out like that, right? So what you need to do is, the most important thing, in which I find very useful, is that we tend to use this Weber's tenaculum or Weber's clamp, which, can somebody hold this? Yeah. So we have a clamp here, and the important thing here is to put the tines of the clamp at the level of the obturator foramen. You have this bony ridge here, which will beautifully hold give hold to the bone, and you put your clamps here, and then you close your reduction, right?
Sir, bone
you have this incision here, you've exposed this, and you'll be able to see this area very clearly. It will never be a problem. So once you have this clamp here, it should be more here. 1 second. Yeah. So the key to reduction is that sometimes you will not be able to reduce it by just one clamp, and it is not correct to use force by just one clamp. Usko crush mat kariye, right? So once you have one clamp, you close it a bit, you have another Weber's tenaculum, and you put it on top of that, and you compress it a little bit more. And then you release the first clamp, you apply the first clamp, and leave the second clamp, and you compress it a little bit more. Right? All this while, if there is a tendency for one hemipelvis to slightly go superiorly, because they will sometimes tend to be like this. So somebody can use a ballpoint pusher, or sometimes I even use the 3.5 bender, which is a very blunt tip, to just push this down while I'm reducing this. So use 2 Weber clamps. If needed, you need to push this hemipelvis down when you're reducing it. Right? One assistant can just help you to push it down, and you put a clamp, compress it a bit, put another clamp, compress it a bit, take the first clamp off, again put that clamp, compress it a little more. Rather than just crushing it like this at one go, you use 2 tenaculum and
do a very gradual sequential reduction till you get a very good reduction. Once you've got a reduction, you take a serum shot, you palpate the top of the symphysis, it should have come in line. You palpate, you just send a finger down to the superior pubic ramus on both the sides, and you find that everything is in alignment, everything is in place. Then you have to go ahead and do in your fixation. So this essentially is the prerequisite. So once you've exposed, we put in 2 Homan, right? I usually tend to use a small blunt Homan which rests on the lateral aspect of both the tubercles. That way you don't do much damage to the rectus. Sometimes though, when it is difficult for this fracture to come back, you will tend to release a few fibers of the recti. It is not always possible to for you to have the rectus totally intact, split and retracted, and then everything falling back into place. So sometimes some fibers do need to get released, the debris has to come out, and then use 2 Weber's clamps, and you will need somebody to push the displaced hemipelvis from the top at times, right? So once you have a reduction, and when you've checked for the adequacy of the reduction, you've checked the retropubic area that you find there, your finger has gone to the superior pubic ramus on both the sides, you know you are in a situation where you've reduced completely, right? So now you can go in and do your stabilization, right? Just a word of caution here, for situations where you have a patient who has both a posterior and an anterior injury, it is not a bad thing to do an inlet view at this point. You have a nice reduction, you have 2 Weber's tenaculum here, your pelvis is stabilized, your patient is supine. Just do an inlet view, see if there is any opening posteriorly. A good and a well taken inlet view on the table will save us a lot of hassle post-op. Because sometimes what happens is, if we are overzealous about going and reducing the anterior pelvic ring without really knowing, or with an additional posterior pelvic ring injury, then the posterior pelvic ring, if unstable, will tend to displace, right? So it's always a good practice to go and do an outlet view before you go in and do a fixation. Okay, so once you've reduced, once you've checked for the adequacy of reduction, if you think you have a posterior pelvic ring damage, you've checked for the outlet views, you can take an inlet view as well, document it. Then the best thing to do is that you need to go in and put in a plate. So these days we have a very good, there are pre-curved plates from Synthes, or the Indian 3.5 reconstruction plates are as good. They can be